Computer. Hi, everybody. Welcome to this edition of Talk with an Expert. Today, we're going to be talking with Sarah, who is a public health and urban planning expert. Welcome, Sarah.
Hi, everyone. Thank you for the intro. I'm going to talk today about how though city planning was born out of a need to protect public health, ironically, today, public health is negatively impacted by both the past and present failures of the urban planning field to center community health in an equitable and intentional way. So laying the groundwork, what do we mean by health when we talk about public health? Health is defined by the World Health Organization as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. There are a number of ways that we can see the legacy of how public health has shaped urban planning. As long as there have been cities, they've dealt with disease in dense environments. And so the ways that we've separated land use, having industrial over here and residential over there, that's the foundation of urban planning, and it's intended to protect humans from the exposures that come from animal waste, air pollution, etc. So once cities reached a certain size and complexity in like human history thousands of years ago, they began to need some form of organization to keep people healthy and safe. On the left is a map from 1850s London during the cholera epidemic, which was this really famous big disease outbreak, which tore through the city regularly, killing thousands of people at a time. And so as the city was growing really rapidly, it needed some way to organize itself to ensure that the sewage didn't end up in the drinking water, which is what was causing the cholera outbreak. And that's how the sewer system was born. So on the right is a drawing of the first zoning envelope from New York City. So zoning is the process by which urban planners divide what uses happen in what places in a city or in a rural setting. So residential, so that's housing, it's zoned a certain way. A business district is zoned a certain way. And for schools, you can't have a school next to a power plant. You know, there's all these kinds of regulations. And that's the kind of private, secret, weird world of urban planning. It's a lot of paperwork. So we don't tend to think of zoning as a public health intervention, but really as a tool to guide the aesthetics of the city, like how it looks and feels, like what it feels like to be walking down the street in a suburban place versus an urban place. But I think it's really interesting to note that the way these masses are portrayed, these like skyscrapers on the right, it looks really dark and dirty. And throughout the history of Western city building, there's been a narrative of dense urban cities as dirty and immoral. But what I think is actually really dark and immoral is the way that zoning codes and the bureaucracy of urban planning as a field have been used for really racist ends, such as through the redlining of poor Black and brown neighborhoods, cutting off an entire generation from access to opportunity and wealth creation through home ownership. So I'm going to talk a little bit about redlining now. So the history, many of us, can track the history of how land use decisions impact individual and community health. But we don't talk that much about how public health has been shaped by planning. So redlining, the map on the left is a redlined map. It was a systematic process happening throughout the 20th century where Black people and other people of color were denied access to equal housing opportunities. And they were limited to areas of the city that were deemed hazardous, indicated on maps in red. So this racist practice, which was legal until the mid-1970s, is commonly referred to as redlining. And these areas actually today still correlate with shorter life expectancies and higher rates of chronic disease. So a chronic disease is something that you don't just get sick and get better. It's like something like diabetes or cardiovascular disease. You get sick and you're going to experience it for a long time over the life course. So as design and planning practitioners, we really need to be talking more openly about the public health implications of these land use policies and patterns. And this gap in articulation has been taken up by environmental justice and other racial equity advocates and organizations who have explicitly called out the racial dimension of how space has been and is controlled through both policies and policing. So, because of scientific advancements in sanitation and bacteriology in the late 19th and early to mid 20th century, while infectious disease rates like cholera plummeted, chronic disease rates like asthma, diabetes, cardiovascular disease, heart disease have really risen steadily. And chronic conditions are actually the leading causes of death and disability in the United States. Chronic disease rates in the US are actually so high that today's children will likely be the first generation ever to have shorter life expectancies than their parents. So chronic diseases due to the environment are really common. They're very costly. They're largely preventable, and they're not evenly distributed across racial groups. So the presence of a chronic disease also greatly increases your risk to acute health threats in already vulnerable individuals and communities, which we've now been seeing with COVID. But we've seen it before with Katrina, with H1N1, with the Flint water crisis, and we're going to see it increasingly with climate change. So something like COVID is an acute moment in time. It's like this crisis, but it compounds the risk that people who have been living in redlined communities, who maybe have less access to health services, have less access to employment, to stable housing, it compounds those risks and it magnifies them. So I really want everyone to understand that the root causes of these disparities in both preventable chronic disease and preventable COVID deaths are shaped by the complicated and really intimate relationships between land use, policy, and place. And to think more creatively about our path forward in the fields of both public health and urban planning, and the unique role that designers and planners and anyone kind of interested in land use and community development and advocacy and racial justice. I really think we need to use what I call this frame from public health, a social determinants of health lens. So the social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the condition of daily life. So I defined health at the beginning. This is kind of the big picture of what really allows you to be healthy, allows you to thrive. So forces and systems that influence health include economic and social policies. They also include things more traditionally related to urban planning, like land use, housing, access to efficient, affordable public transportation, access to open space for recreation and social gathering, work and school environments, and access to healthy food options. So it's really vital for practitioners across the two fields that I work in to use a social determinants of health lens when we prioritize, fund, and promote short-term land use and design strategies to respond, for example, to COVID, because research has demonstrated time and again that environmental improvements intended to support health predominantly benefit people that are already socioeconomically advantaged and racially advantaged. And that inequality in the built environment both underlies and exacerbates key health disparities in things like physical activity, obesity, and the vulnerability to acute health stressors like heat waves from climate change, et cetera. So I really think in public health and urban planning, we haven't been centering health enough in our work. Or in urban planning, we haven't been centering public health enough in our work. And if we did, our roadmap might look something like this. So social determinants of health research can get pretty wonky with like a lot of lingo, but the really important takeaway is that upstream social inequities lead to inequitable environments, which then either enable or inhibit those individual health behaviors like exercise, nutrition, that have been overemphasized in many conversations about public health and urban design. So for example, a strategy to respond to COVID has been to create slow streets in a lot of neighborhoods, where they close off the street to through traffic and say, you can only drive on this street if you live here, with the idea that, you know, children can play on the street, people can walk, it'll make it easier to social distance. And it tries to promote recreational biking and walking during lockdown. But, you know, strategies like that really need to consider upstream hazards to public health, like police violence, or the reality that in many communities, disinvestment in the built environment, such as a lack of safe parks and bike lanes, compounds the impact of socioeconomic barriers to health, such as a lack of time for recreation, the higher likelihood that residents of disinvested communities would be breathing polluted air in the areas around their home, the higher likelihood that those residents of those communities will be frontline workers that don't have time to do recreation. They need to go to work every day. And so what they actually need are healthy, safe ways to get to and from work and to care for their families. So land use planning and design obviously fit in the center of this graphic here, but they also impact things all along this kind of upstream, downstream health pathway. And land use designers can shift the conditions that promote certain health behaviors on the downstream side by shaping environments where the healthiest choice is always the easiest choice for people of all ages, abilities, races, and incomes. And crucially, you know, I think that designers can use our platform to support shifts in policy and the centering of the voices of those most impacted by social and institutional inequities on the upstream side.
Mm-hmm.
So as we land use planner folk design short-term strategies to reduce COVID-19 risk, we really need to be doing so in alignment with long-term health promotion goals through a social determinants and a racial justice lens. There's a lot of talk about the potential to use what's called tactical urbanism to immediately retrofit our cities and experiment with using space in different ways. So that's like closing down an alley and letting the restaurant have all of its seating outside. But while we're working on these short-term solutions to space, we really need to be thinking about who benefits from these strategies in both the near and the long term. So here's another redlining map. Our past has really shaped the present moment, and your zip code where you live is more predictive of your health than your genetic code. It really, really matters where you are and what you have access and exposure to. This redlining map on the left is of San Francisco. And you can see that the areas that were historically redlined, this is pre-1970s, where Black and Brown individuals and families were denied home loans and were denied access to stable and affordable housing, which kept them from being able to build intergenerational wealth, are today experiencing the highest number of cases of coronavirus per capita. So these numbers are from May on the right. This was a presentation from a couple of months ago, but the numbers are going to be consistent across all major metropolitan areas. And these patterns of exposure in poor Black and Brown neighborhoods are tragic and disturbing evidence of racial differences in our country at a time when the media tells us that, like, we're all in this together, that COVID is this great equalizer. But people know that that's not true. It's not true for them. It's not true for their families. It's not true for the populations and the communities that they care about. So racism is really the upstream driver here. It's what shapes social conditions that create more risk in vulnerable populations. And data can be a really powerful tool and can help us understand who's benefiting from various strategies. It's really important to have disaggregated data, which means we're not just saying who is getting sick and who is dying, but who, of what races, of what ages, of what immigration status is getting sick and who is dying. What's happening to the disabled population? What's happening to older adults? There's what's happening to people who are unhoused, to people who are incarcerated. So that's what disaggregated data means, is really being able to see the details and see the forest, see the trees through the forest, as it were. So there are increasingly great resources that some great organizations are providing public health professionals on this disaggregated data, so we can really tease into the racial and different demographic age category elements of what's happening with COVID. In the state of Michigan, where Black people make up 14% of the population, they make up 40% of the COVID deaths. This is as of May. In Indiana, where Black people are 32% of the population, makes up 70% of the deaths. So this data is horrifying, it's alarming, but it's not surprising. And equally unsurprising are the explanations that follow, where people say that Black people are more likely to die because they're more likely to have underlying conditions, such as hypertension, chronic lung disease, cardiovascular disease. But institutions and policies shape the conditions that make this the case across the social hierarchy that exists in our country. And Black and brown people live sicker and die sooner in the United States. Racism determines your exposure to a lifetime of risk for poor health overall and poor access to a host of health promoting resources. Jim Crow, mass incarceration, stop and frisk, these things have made it almost impossible for Black people to have the same opportunities for healthy lives and communities as others. So stress in our bodies is like a continual fire that erodes our body's ability to care for itself. And chronic stress from racism can really destroy people's ability to process infection. It can also heighten inflammation, and it can suppress the immune system. So these are the details. These are the mechanisms by which the social policies, the prevailing attitudes of our country and of communities impact the bodies of the people inside them. So recently, as I mentioned earlier, a number of cities have implemented these slow streets, where they close the streets to through traffic so that people can use the street as an open space. But if we look at a map of incidence of COVID-19 on the right, alongside the map of slow streets that rolled out as the first batch of slow streets in San Francisco, we can see that these areas are some of the most underserved for this immediate COVID-related intervention. So particularly that southern circle at the bottom, where there's also very limited access to open space compared with the rest of the city. So an organization that I really admire put it really wonderfully. You know, they said freedom of movement in the current context means having the choice not to move at all and being able to work from home. While we're facing unique challenges, what is not unique is that the most marginalized have the least choice to stay safe. So we're currently in a time that an author, Thomas Pueyo, beautifully named the hammer and the dance, responding to this pandemic. The hammer being shelter-in-place orders, where everything is locked down, and the dance being the time that cities and states start to step back out into the world, testing different ways to organize with social distance. So this is a time of great experimentation in our cities, absent federal direction on things like masks, on federal instruction on things like schools. We really need to continue to remember the lessons learned from our inherited history of planning and public health. And as we implement these ideas, we should make sure to think about the racial legacies and implications of our short-term strategies and solutions, so that we can build a progressively more equitable future. So in closing, this is a list of questions that I pose for the benefit of design, planning, and land use professionals to consider for COVID-19 responses in particular. How would the practice of urban design and planning change if we used public health outcomes to guide our work? What sorts of expertise might be necessary for a workforce that can really engage with upstream drivers of health and anti-racism? Who would we partner with? What other actors should we engage in conversation? What would we do differently if we designed for the most vulnerable users first? And how might urban planners and designers apply the rigor of public health to actually measure individual and community impacts of urbanist interventions?
Wow, that was really awesome, Sarah. Thank you so much for taking the time to talk with us today. I think everyone will have learned a great deal about the places where we live and what kinds of questions we can be asking ourselves.
Thank you so much.
All right.